This is a video about the arthroscopy without traction using an inside-out technique for treating femoroacetabular impingement syndrome. The patient is placed horizontally supine on a conventional operating table without perineal column traction. Special soft jelly pads are placed on both sides of the iliac spines to fix the patient's torso. The patient's feet are placed in cushioned boots, and then the patient's lower limb on the surgical side is bent 90 degrees and the hip is bent 30 degrees, and the legs are fixed in an internal rotation position of 15 degrees. Mark bone markers on the patient's skin and plan the entrance under arthroscopy. The anterior lateral approach L is located at the anterior inferior iliac spine, 2 cm in front of the apex of the greater trochanter of the femur. The middle anterior approach MA is located 5 cm away from the AL approach and approximately 2 cm forward. The anterior approach A is located about 4 cm downwards and 3 cm outwards from the anterior inferior iliac spine. At this point, the 3 surgical approaches form a pattern resembling an equilateral triangle. Firstly, it is recommended to use the anterior lateral approach L to insert a lumbar puncture needle. The endpoint should be felt to penetrate the joint capsule and enter, and the position should be confirmed under C-arm fluoroscopy. The ideal insertion point is below the femoral head-neck junction, with the needle just sliding over the anterior edge of the femoral neck. Insert a 30 degrees arthroscope and inject physiological saline to establish the operating space. After confirming its location within the joint cavity, the lumbar puncture needle is inserted through the midline approach. Under arthroscopic monitoring, the lumbar puncture needle is confirmed to have entered the cystic space, and a trocar is placed to establish the working port. Use a 90 degrees radiofrequency cutter to longitudinally cut the joint capsule from inside the joint to outside the joint along the posterior bundle between the V-shaped iliofemoral ligaments. Explore the femoral head cartilage and glenoid. Continue to use a 90 degrees radiofrequency cutter to expose the surgical field. Using a probing hook can determine the location of the labrum injury. Use a power grinding head for acetabular shaping to freshen the base of the labrum. Insert the positioning needle along the anterior approach. Confirm under arthroscopic monitoring that the lumbar puncture needle has entered the cystic space, and place a trocar to establish the working port. Insert 2 to 4 rivets into the base of the labrum. Use a sewing hook loop to sew and repair knots. Use a power grinding head to remove supernumerary bone and grind it to the junction of hardened bone and cancellous bone, ensuring even and mild bleeding on the bone surface. After the surgery is completed, standard joint capsule closure is performed using non-absorbable high tensile strength sutures and or non-absorbable sutures in an edge-to-edge manner.